Good afternoon to everyone present here. The topic of my presentation is the prosthodontic management of mucormycosis resultant defect from post-surgical phase to functional rehabilitative phase. Introduction. Mucormycosis is an invasive opportunistic fungal infection commonly affecting the immunologically compromised and had risen to prominence in the aftermath of the COVID-19 pandemic, with the rhinocerebral variant being of particular relevance to the dental practitioner. It is characterized by involvement of the maxillae, paranasal sinuses, nose, and even the orbit. The disease is conventionally managed with surgical resection and antifungal therapy. Reconstructive surgery may not always be feasible for the rehabilitation of these patients, in which case prosthetic rehabilitation may be resorted to for the restoration of the patient's ability to masticate, swallow, and articulate. The fabrication of a prosthesis, however, poses certain challenges, such as lack of favorable anatomical undercuts and the absence of a proper peripheral seal. This case report demonstrates comprehensive prosthetic rehabilitation of a post-mucormycosis defect from using an interim obturator to a definitive hollow bulb obturator. A 66-year-old male patient reported to the Department of Prosthodontics complaining of regurgitation of food into the nose while eating food. The patient gave a history of having undergone surgical treatment for rhinocerebral mucormycosis a month ago, and he is also a known diabetic and is on oral hypoglycemics. Extraoral examination showed facial asymmetry with depression of the left midfacial region. Intraoral examination revealed an elliptical surgical defect of approximate dimensions 5 mm by 2 mm involving part of the palate and the residual alveolar ridge corresponding to the region of the left maxillary canine till the left maxillary tuberosity. In addition, the retained roots of right maxillary second molar were present, and the mandibular arch was fully dentulous, and both dental arches had generalized gingival recession. Now, the treatment plan, since the patient had been on antifungal therapy with active purulent discharge from the defect at the time of presentation, it was decided to provide the patient with an interim obturator to facilitate per-oral intake of food. While the defect would heal completely and become dimensionally stable, a definitive obturator would be provided after that. It was also decided that the retained roots of the right maxillary second molar be extracted prior to fabrication of the definitive prosthesis. The absence of bone of adequate quantity and quality precluded the use of implants to augment the retention of the definitive prosthesis. The generalized periodontally compromised state of the dentition ruled out use of any crown retained precision attachments such as the Sagix or the vertex attachment systems. So it was planned to prosthetically rehabilitate the patient using a clasp retained definitive prosthesis with a hollow bulb using the anatomical undercuts of the defect for retention. So initially, an interim obturator was provided for the patient, and this is in the prosthesis in situ. This is the condition of the prosthesis a year after, with periodic follow-up. And as we may see that the prosthesis had to be relined using tissue conditioners as the defect was healing and dimensionally changing over the course of time. Once the defect had stabilized, we had proceeded to make the primary impressions for the fabrication of definitive prosthesis. The primary impressions were made using irreversible hydrocolloid. The definitive impression was made using addition silicone impression material, followed by the recording of the maxillomandibular relations, which were mounted on a semi-adjustable articulator. This was followed by a try-in of the prosthesis, and this was the definitive prosthesis after acrylization. In order to reduce the weight of the prosthesis, a hollow bulb had been incorporated. To make the bulb hollow, the lost salt technique had been used, in which the salt had been incorporated into the bulb during the process of packing, and the salt was drained after acrylization by drilling a hole in the intaglio surface of the prosthesis and injecting water through that hole. This resulted in a decrease in weight of the prosthesis. This was the definitive prosthesis in situ and the pre-rehabilitative and post-rehabilitative frontal profile views. The discussion. Now, the prosthodontic management of maxillary surgical defects is done in 3 phases: the surgical, interim, and definitive. Surgical obturator is inserted during surgery, acts as a matrix to hold the surgical dressing. The interim obturator is placed at least 1 week following surgery. It is removable and can be adjusted during the post-operative healing period. Once the defect becomes dimensionally stable, a definitive maxillary obturator is fabricated. This is usually at 3 to 4 months after surgery. The treatment planning for prosthetic rehabilitation of surgical defects is guided by the morphology of the acquired defect, followed by the patient's aesthetic concerns and the financial situation. Now, a majority of the elderly post-maxillectomy patients are not suitable candidates for implant placement because of absence of bone of adequate quality or because of concomitant polypharmacy because of other systemic comorbidities. So it was decided to rehabilitate the patient using a removable clasp-retained obturator, utilizing the anatomical undercuts to augment the retention and to incorporate a hollow bulb to reduce the weight of the prosthesis. The lost salt technique was employed for hollowing the extension of the obturator to the defect due to the relative ease and simplicity of this technique compared to other conventional methods. Conclusion: in terms of the patient's need for both aesthetics and function, this single-piece fully hollow design used in this case proved to be an excellent rehabilitation technique and allowed us to maintain the prosthesis weight as low as possible, leading to greater patient acceptance of the prosthesis and overall improvements in mastication, phonetics, aesthetics, and the quality of life. These are my references. Thank you.